The other times that we would get involved more commonly, I think, as clinical psychologists, is if there is any evidence of, sort of some strong emotion-related responses, sort of tears, sobs, laughing, just to see whether that's contingent on what's going on, or if it seems to be just totally internally generated. And we will also get involved if there is any behaviour that's challenging to manage. So with these sorts of patients, that's not usually intentional, but you can have, kind of roaming hands, for example, which are knocking into trackies, fiddling with everything around, and it fiddles with the peg, fiddles with the clothes, you get pads that end up being off, and it's not that the question that arises is this something that the person is doing intentionally? Some,times it gets referred to us as this patient is smearing. Now, smearing carries, the implication that it's intentional, that somebody is deliberately doing that, whereas more frequently, if the patient is, is sort of minimally conscious state, it's simply, roving hands are encountering whatever there is to encounter. So, the effect is the same, but the intent isn't. I don't know if that makes sense, but those are the sorts of things that I think that we would get involved with patients, which are much more about looking at individual patients and emotions or behaviours, I'm going to correct myself there, because one of my pet bugbears is when we get emotional labels applied to PDOC patients. So, for example, people saying to us, well, you need to see this person because they're depressed. Now, this person, if they're in this state, they're not capable in any way of reporting depression. What we need to say is, no, what you're seeing is a behaviour. Let's just say you think they're withdrawn. Well, most of these patients do present as withdrawn, or you're seeing some tearfulness. Let's come and look at it. Let's look at how often we see this, how intense it is it triggered by certain things, and if we do try any sort of intervention, how are we going to monitor whether it has any impact? Rather than put emotion labels on, let's think of it as a behaviour and see what we can learn about it.
So it might be you as a care staff are observing tears. So what do you then do at a practical level? This is a patient who has been observed as tearful on several occasions. What do you practically do?
It's a great question, isn't it?
The meaning of the tears.
I think, so what do we do? We would certainly, I say, we've always got that dilemma of records or not records, because if you ask care staff and so on to fill in endless forms about when they see things and what was going on before that and what they did and did it do anything, you often get very incomplete records. So we might try and get some records. We would certainly talk to the staff, try and gauge what they see. We'd observe the patient, so if they think they're seeing tears at particular times where it does seem to be contingent on something that's going on, let's just say washing and dressing, we'll go and have a look, and we will always talk to the family and see what they see, and what do they do. It doesn't mean that we'll always end up with a definitive answer, because again, we're always left with the situation here that the patient can't tell us. So, you can't sort of dissociate the person from before their brain injury and say, well, if you were behaving like this, how would you be feeling? It doesn't work like that. If it does seem to be an issue that's, sort of fairly frequent and is causing concern, and perhaps maybe, for example, pain related, then, we'll be having MDT discussions anyway, but it's very likely that, the doctors will be thinking about, should we put another analgesic in, or should we, try an antidepressant or something like that. And it may well be that as a team, we agree that that's something worth trying, but then we're thinking about, so how are we going to see if it changes anything? So we're back to records, observations, and really good team and family discussions.